Good afternoon, and welcome to Infectious Disease Grand Rounds. There is no commercial support. The speakers and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. A link to the event survey will be shared at the end of the program. I would like to introduce Dr. Supriya Manapalli, who is our Medical Director for Infection Prevention and Control.
Thank you, Jennifer. Today's speaker for ID Grand Rounds is Dr. Siddiqui. Dr. Siddiqui joined NGHS in August of 2022 from the Medical College of Georgia in Augusta, where he was an assistant professor for over 3 years in the Division of Infectious Diseases. He works in the Gainesville Infectious Diseases Clinic, seeing hospital follow-ups and new referrals. He sees a broad range of infectious disease cases. Some examples of fascinating rare cases he's encountered are cutaneous leishmaniasis, psittacosis, endocarditis, and babesiosis. On his free time, he enjoys biking, swimming, and baking with his wife and 3 little kids. Please join me in welcoming Dr. Siddiqui.
Good afternoon, everyone. Thank you very much, Jennifer and Dr. Manapalli, for the introduction. It's nice to be back here. It's been a while. Thanks for all those who are here. And for those virtually, I do the same thing on a rainy, cold day today. And I thank my staff. I work in the clinic and can't do it. I couldn't do anything without them. And they were so nice enough to join me here today. So thank you, Lisa, Melissa, Maria, and Christina, and I see Dr. Brester there too. Oh, and he's the great addition to our team manning everything, and really appreciate learning a lot from him with different cases. So my talk is on travel-related infections. I really enjoy, I haven't been around the world as much as I'd like to, because I have little kids, and we went once to London and Paris, and it was not really an easy experience, because they tend to walk a lot more, which is good, and public transportation, and they don't have as many elevators, lifts they call it, so that you have to pick up the stroller and take them up. But wherever we go, there's always things, bugs that we may encounter, and it's fascinating, talking to patients when they're traveling. So just a little bit of epidemiology. Travel is increasing. In 2015, international arrivals in all countries exceeded 1.2 billion people. As you can see with this graph, it's showing it's increasing over the years, and majority travel to Europe and then the other continents. This is just showing different journals and the amount of them, how they're increasing as well over the decades, and more and more interest. So out of 4 studies, there's an estimate of 43 to 79% of travelers who frequently visited developing nations such as India, Tanzania, Kenya became ill. So about half at least. Most of these illnesses were mild and self-limited, like diarrhea, skin and respiratory infections. Some travelers return to their own countries with preventable life-threatening infections. I always find this range funny, but the statistics, 20 to 80% travelers actually do not seek any travel medicine clinic advice. Data about the effect of pre-travel advice is limited, although such advice has a positive effect on prevention of malaria, at least. Travelers usually visiting friends and relatives in their country of origin are the largest group of travelers that highest morbidity, especially for malaria and typhoid, and the rates of infection higher in the summer. Approximately 8% of travelers consult a physician either during or after a trip, but only less than 1% require hospitalization. Infectious diseases account for about 10% of morbidity, but only 1% of deaths, which most common is from malaria. Causes of death vary according to the population study. Elderly travelers may suffer mostly morbidity and mortality from cardiovascular issues, whereas developing countries, motor vehicle accidents and drowning prevail for the younger. So providing vaccine based on risk exposure, it depends, taking the itinerary into account and severity of the disease and any risks with the vaccine itself as well. Some of them are live and have different side effects that I'll touch on a little. And so in terms of statistics, hepatitis A only 0.03% per month, so it's considered low risk, but still a risk, and hepatitis B higher, 0.25% per month, and it's usually more in long-stay travelers and expatriates. Enteric fever, typhoid, paratyphoid is 0.03% per month, and it's on the Indian subcontinent, and is 10% lower in Africa and Latin America. The risk of yellow fevers is 0.1% per month, and that's travel to current epidemic transmission, but risk varies greatly between destinations encompassed by the endemic area map, and I'll go through some of that. So the meningococcal meningitis, rabies, cholera, polio, measles, varicella, and Japanese encephalitis are actually very small percentage, 0.001%, even in the highly endemic areas. But these are very fascinating, and oftentimes, we test for them because they can be very severe, life-threatening. So just a brief note on the travel notices. So CDC uses these 4 levels. Level 4 is to avoid all levels. Thankfully, right now, there's no level 4 notice. Level 3 is to reconsider non-essential travel, and currently also not any notices at this level, but you have to check every time you're traveling because things change at any moment. Level 2 is practice enhanced precautions, and those are some of them: global polio, monkeypox, chikungunya, and right now, also recently, last week, is the Ebola in the Uganda. There's an outbreak there. And then level 1 is practice usual precautions. So just, I like maps, and I haven't been there yet, but that's where actually my ancestry, my father was from Hyderabad, India. It's like right there. And so chikungunya is a virus. They tend to come up on the boards. Like a question they like to say is if somebody has the chronic joint pain for a very, very long time. That's one of the classic things. And there's a vaccine. It's live, so it's recommended if you're going there. But if you have a weaker immune system, avoid it. Obviously, the infection starts 3 to 7 days after bite, and it's usually fever, joint pain, swelling, and rash. It may improve, but as I said, the joint pains tend to persist months to years. Oropouche virus, I'm not sure if I'm saying properly, but in Brazil, it's transmitted by small flies and mosquitoes. Again, short incubation period, 3 to 10 days, and lasts for 3 to 6 days. Headache, fever, myalgias, nausea, vomiting, and severe cases may get meningitis. Most recover without sequelae. There's no specific treatment, and it can be sexually transmitted as well, so you have to caution patients about that up to 6 weeks after returning. This was a recent malaria outbreak in Ethiopia, and I'll be talking about more regarding malaria. So because there's high risk with some of these infections, patients that request for vaccination, it's not unreasonable, to consider. And so things to risk assessment for the travelers is knowing exactly where they're going and which countries they may be just having a layover, but and then their risk of assessment in the seasonal what season they're going, also also what activities they're doing, their age, the vaccination history, if they have any immunocompromised status, if they had any prior travel-related infections, then you have to know, like with everything, their medication, pregnancy status, allergies. So just briefly, I'm not going to go through all of this, but this is something Dr. Bressler was talking about as well. Maybe we could introduce in our clinic because we don't have any vaccines, but it's good to, it's a nice thing to have, and it's easy to vaccinate. There's low risk. I mean, some of these are really cool, you know, talking about the patient too. So the live typhoid, you know, you put in the refrigerator. There's a killed one, intramuscular, but that lasts only 2 years. The live one lasts you about 5 years. Twinrix is better to have if instead of having 2 pokes, just one per Hep A and B. Then there's the varicella, flu. Yellow fever is live, and there's actually been some side effects, you know, adverse reactions with that one as well. You can get a neurologic type of side effect that's severe, and also a visceral, like which is may affect other organs, liver, etc. Meningococcal is recommended to people who are going to Mecca for pilgrimage, so I had to get that one 10 years ago, and also like in the Army. Rabies, so any animal exposures where oftentimes, these are very expensive, like immunoglobulin rabies and the vaccine, but very important, you know, to consider in animal bites and exposures to bats. On the boards, they like to ask about, they'll give you a scenario, you know, a bat just comes in the room, or dog, you know, they have to monitor, so they tend to like those type of questions. Japanese encephalitis and all these other encephalitides are something cool we sometimes order, you know, serologies for. And then there's a cholera live attenuated vaccine as well. This is an interesting, you know, statistics. I'm not sure how accurate they are, but 5 new human diseases every year, and 3 of them are animal origin. And so it just shows a lot of burden of disease infection is related to animals and wildlife interaction. So 60% of existing human infections are zoonotic. 75% emerging, such as the Ebola, HIV, influenza, have animal origin. And 80% of agents with potential bioterrorist use are zoonotic pathogens. But I still love animals, and my kids have had all different types of pets, from turtles to lizards and birds. And so just quickly going through, like, this is the cool part of ID that I like, because you get to, you know, associate all these different types of animals with different types of infections, and, you know, as it's just broken up from bacterial, viral, and fungal, and you can just glance over all these and see how there's so many different infections you can get from different exposures. So cautioning patients when they're traveling, you know, to avoid too much interaction. Psittacosis, which was one of the cases I had with the endocarditis, is very fascinating. Capnocytophaga comes on the boards as well. The dog bite, you know, sometimes you can, more common somebody who's asplenic. And rabies, and then the monkeys, we don't have too many of those here, but if you go in Africa and Asia, the rodents, there's plenty of them, different types of infections you can pick up. This is gonna be a little overwhelming slide, but I just put it because you find this in our infectious disease textbook, Mandel, that pretty much gives you a nice reference for the incubation period, which is one of the big things with infectious disease. You know, in somebody returning traveler with fever or something, we always need to know when did their symptoms start. And so, but it can oftentimes overlap as you'll see with malaria, it's on all, incubation periods with, from 14 days to the longer, to months. And the longer incubation periods, some of them are parasitic, TB and hepatitis, and then malaria, melioidosis that sometimes comes up on internal medicine boards as well, like burkholderia. And so most common causes of fever after travel is malaria, dengue, chikungunya, mononucleosis, rickettsial infection, typhoid, and paratyphoid. In addition to travel-related infections, cosmopolitan causes of fever should be considered. So I'll just be going through some of these infections. Malaria, there's estimated 260 million cases and 445,000 deaths in 2016. Approximately 40% of the world population is at risk for acquiring malaria. And it's interesting that the newer drug, this coartem artemisinin-based combination therapy, has had some failure in patients with Plasmodium falciparum in sub-Saharan Africa. We're hoping to have more drugs down the way. So primary attacks, approximately 8 to 25 days, but maybe longer. Depends on the immune status, the strain and species of Plasmodium, the dose of the sporozoites, and possible effects, partially effective chemoprophylaxis, which I'll go in a little bit. Relapses from latent hypnozoites, the Plasmodium vivax and ovale, can develop months to years after mosquito bites. So I don't think I added, but there's a nice, CDC has the life cycle of the malaria parasite and how these different species can reproduce. Late onset recrudescence falciparum may occur in individuals who have suppressed parasitemia, drug-resistant parasites with chemoprophylactic drug. So treatment should be initiated emergently because of the morbidity and mortality. So chloroquine for the chloroquine-sensitive areas, which would be some places south. You always have to refer to the CDC for the maps, but some areas in the Central America, Mexico, and then also some parts of China or Middle East, but Asia, Southeast Asia, Africa, mostly going to be chloroquine resistant. And for chloroquine resistant falciparum and vivac, if it's uncomplicated, tovacone or artemether. For the liver stages, for vivax ovale, it's maybe treated with primaquine, and it's contraindicated with G6PD. And there's a newer derivative of that, tifanoquine, which has a longer half-life, so easier administration. So important differentials for somebody you think may have malaria, flu, enteric fever, bacteremia, sepsis, dengue, schistosomiasis, leptospirosis, trypanosomiasis, African tick fever, and yellow fever. Dengue, which I've had a couple of cases of dengue I've seen since being here. It's transmitted by the Aedes mosquito, Aegypti, and Apopictus. From 2000 to 2019, the WHO reported worldwide 10 times increase in cases from 500,000 to 5.2 million. So that's not good. Again, broad range, 40 to 80% are actually asymptomatic. So symptoms, you may have mild to moderate, non-specific acute febrile illness. Less than 5% actually develop severe life-threatening disease. Early finding are non-specific but require high index of suspicion. Recognizing the early signs of shock and promptly initiating intensive supportive therapy can reduce risk of death among patients with severe dengue by about more than 20-fold. This is just a picture of how the rash could look. It could be macular rash that appears 4 to 5 days, but it can be also faint flush-like rash too. There's a map showing where dengue is. So Africa, Asia, and South America. Diagnosis, the serology, as you could see, is it depends on the timing, the days of onset, the fever's beginning, and then initially you can look at the RNA, but that will go away, so you can check serology later if the patient wants to know what they had. The treatment is going to be hydration, and to avoid anticoagulants, including aspirin and NSAIDs, to control fever, to use Tylenol and sponge bath. Prophylactic platelet transfusions are not beneficial either and can contribute to fluid overload. And similar steroids have not been shown to benefit and may have some harm. A little bit about Zika. That's the map for Zika. It's a flavivirus related to West Nile, dengue, and yellow fever. It was first described in Micronesia, transmitted by Aedes mosquitoes. Incubation is about 5 to 6 days. They get a rash, fever, arthralgia. And I remember I was a fellow when I first encountered this first case of seeing Zika for me. And somebody who had come travel with fever and had the rash. But it's just supportive treatment. And you have to, also it's sexually transmitted, so for men should use condoms or be abstinent for at least 3 months, and women at least 2 months. And that's one of the pictures of a rash, how it can look maculopapular, typically itchy. And I think this is coming too close to the end of my discussion. So this is interesting, article that was showing that ESBL UTI is actually increased. We see a lot of UTIs related from travel, and so the recommendation is avoid low and middle income countries with travel, and strategies to help. Number one, advise urine cultures from all UTI patients returning from those countries and that have resistance. Number two, take recent travel into account and when selecting antibiotic prophylaxis for males undergoing transrectal prostate biopsy. And number three, stress travel-related diarrhea prevention and non-liberal antibiotic use in pre-travel counseling. And I think that's it. So I guess I would just add one thing, like we tend to use antibiotics a lot, and it's studies show probably 50% of the cases, 50% of the time not needed the antibiotics, and 50% of the time it's ordered longer than necessary. In regards to travel, what I would tend to say is if, wait it out, and if they need to, that you can take usually antibiotic for travelers' diarrhea. Most of the times it seems to be very self-limited, that you can give them an antibiotic, Cipro or something. But again, using the CDC website any time somebody's traveling to figure out what type of exposures they may have and what type of activities they're going to be doing. So if somebody's going to a 5-star resort, you're not going to be as concerned for these type of infections than somebody's going to, going to Amazon and like swimming and interact with the wildlife and doing a lot of other activities, being very sexually active, promiscuous, then you're going to be much more concerned and provide much more vaccinations and advice, to prevent. So just a couple of questions. I'm not sure if we have any residents in-house or online. So an 86-year-old Asian male is traveling to India. Which of the following is true? A, chikungunya is not known to be a risk in India. B, malarial prophylaxis is needed, including in the mountains, more than 65,000 feet. C, the most likely cause of death would be a cardiovascular event. And D, all of the above.
Dr. Siddiqui, you want us to answer the question?
Yes, please.
Okay, excellent. I got to phone a friend. Here we go.
I'm going to go with D, all the above.
Okay, and anyone else would say anything different?
April, you might be wrong. C. C. We're going to go C.
Okay, we have a vote for C then?
Vote for C.
Okay, yes, C is the correct answer. So as discussed, the map I was showing that those two areas, I don't remember the name, Dr. Manipali would remember. Those two provinces that are currently having a chikungunya outbreak. Malaria, it's actually less likely if you're higher elevation. The rest of the areas you do recommend malaria prophylaxis, and that cardiovascular events would be the most common, in that age. Second question. So 35-year-old Caucasian females traveling to Brazil. Which of the following would you recommend to prevent Zika? So A, mosquito precautions only. B, mosquito precautions and avoid sexual intercourse for 2 weeks before and 2 weeks after returning. C, mosquito precautions and avoid sex for at least 2 months. And D, take atovaquone for 2 days before and 7 days after returning.
We are going C
Okay.
on this question.
All right, very good. So it's going to be mosquito precautions are something you're going to recommend to everyone, I would say, even around here. And so I didn't talk about that, but DEET is a good one. You can get any store, and 50% probably is better. Just spray it on, and when anybody, of course, who's going out more, but peak times are like dawn and dusk, and any water, if they're around bodies of water. We recommend like long sleeves and wide brim hat. And then, but still, if they're in the area that there's going to be malaria, we recommend malaria prophylaxis, and I didn't get into that, but there's different options. And it's usually taken like before, start a couple of days before and take it after. But as far as this question was just talking about, like in terms of sexually transmission, so it's just one of the things, one of the methods for transmission for that. And yeah, I think I'm done. I guess finished earlier than I thought. So travel, but enjoy. Take your precautions. Any questions?
Excellent, thank you. If you're viewing online and you have a question, please enter it into the Q&A section. And then if you're in the room, we'll let you hold the microphone so our folks online can hear. Any questions or comments? Yep.
That was great. And, you really sort of covered the waterfront and the air front and everything. I was curious when you were researching this, there's been a lot of chatter maybe in the past year or so about dengue especially, but spread within the continental United States in cases without any known travel exposure. If any of that came up, or if you're seeing any sort of recommendation changes based on that risk.
I didn't actually. I'm not too sure. But I think there's always that concern, these type of vectors migrating and keep coming up north, like Zika and chikungunya. I think there's, that's always a concern. But I don't recall like cases, originating from U.S. Some of these mosquitoes are also like similar ones that we have in the U.S. that transmit all these type of viruses. So
Thank you, Dr. Siddiqui, for always supporting the ID Grand Rounds and for a talk today.
My pleasure. Thanks for having me.
I think, Dr. Bressler, I just pulled up the AI version of the answer to this, the dengue. It says that it's endemic in Puerto Rico, one of the U.S. territories, but I think we've had cases in Texas, basically southern Gulf Coast regions, and also Hawaii. So yeah, I think when Dr. Siddiqui gave the talk about global warming, I know you touched on some of these infections we normally don't see in US that we're seeing, malaria, dengue. The two provinces in India that are having the chikungunya currently are kind of in the middle part of India, Maharashtra and Telangana. So you may have heard of the city Mumbai and, kind of close there, or Hyderabad. So those are the two provinces that are having the chikungunya outbreak. And thank you for touching on the ESBLs as part of the travel. I read an article recently, especially specific to India, where they said pretty much any E. coli that you isolate at minimum would have ESBL resistance. I thought that's become pretty much the norm there.
Very good. Thanks so much. I still have yet to travel that part of the world, my homeland, my mother's land. But I mean, it's always interesting talking to family that comes from there, because I mean, I have patients who ask me where am I from, and I'm like, well, I was born and raised in Toronto, Canada, but my parents are from that, Pakistan, India, and I've never yet been there. But there's definitely nice places to see and things to eat there. But yeah, the biggest concern is like the GI I hear from, and when I was in travel clinic, we would say, make sure that the water, try to drink bottled water, and make sure that the seal is intact, because sometimes, I don't know how true that is, but if they refill the bottles and give it to you. And salad also, sometimes you may think, I'm going to be healthy and just have a salad, but those can also be contaminated too. So sometimes having something that was cooked well would be less likely.
Hi, Butter. Thank you so much for that talk. It's always a great topic of discussion, and I really enjoyed it.
Thank you.
Just a little interesting fact. Several years ago, I think it was about 6 or 7 years ago, before I actually had my kids, we had traveled to India, and then there was a blood drive. So I volunteered to go, like I usually do, and they asked about, recent travel, etc. And I think just came back from India, I want to say within like a couple of weeks of that. And the specific area that I had gone, which is Kerala, where I was born, one of the southernmost state in India, they actually refused to take my blood because that area is actually considered endemic for malaria. So they didn't take it. I actually, I'd given blood before and I'd never actually thought about it. So I thought it was really, really interesting. Just wanted to share.
Thank you so much.
Learned something new at that time.
Yeah, it's hopefully when our kids are older, we could travel more. But yeah, it's tough. And in those countries, I mean, lots of culture. I mean, there's so many languages and things to eat and see.
I have a question. So actually, my mom had chikungunya maybe about 15 years ago or so. I was wondering, what is the likelihood, or is it possible to get reinfected with illnesses such as chikungunya or dengue?
I'm not aware of it being causing like a chronic infection. Dr. Bressler or colleagues can chime in, but I don't know of it being something that's kind of like we sometimes hear about chronic Lyme. We don't have evidence to say that's a chronic persistent infection going on. It's just kind of sequelae of the infection. Would you say the same? Not sure.
I don't know specifically for chikungunya, but since the presence of the vaccine suggests that immunity is lasting, dengue is a little bit different because there's different strains or types, and you can get reinfection with different types, and sometimes reinfection is actually what leads to worse disease based on the immune response. So.
Yeah, chikungunya immunity can be lifelong, at least theoretically, but not for dengue.
Thank you very much, everyone, again.